you? Are we audible?
Alim, you are in your clinic? Alim?
Yeah. Yes, sir. Rajni ma'am also there. Rajni ma'am, good evening.
Alim,
Hello, welcome.
can you hear me, Dr. Topan? Alim, can you hear me?
Loud and
Yes,
clear.
yes, I can hear you.
Okay, I
Clearly.
just have to inform you that I had told Dr. Topan that I'm going for testing.
Yeah.
My wife has turned out positive. So I will leave this meeting. I will request Majid Bhai to take over. I express my deepest regrets that I would not be able to chair, because we have to now move towards isolation and take those precautions, as I work in a secondary care center. So all the best for Anisha madam. I'm sorry, I would have loved to sort of chair this session. However, we have just got the report saying that RT-PCR is positive for my wife, and I will have to be tested, and our contacts have to be tested. So all the best to you guys, and Rajni madam also.
Thank you very much, Dr. Dhume. We pray
Amrit, I'm sorry.
that
Sir, please take care of madam. Please take care of yourself.
Get well soon. Be back.
All right.
We'll again
Be
meet
in
on
touch,
this
sir.
call.
Although we don't have, thankfully, symptoms, guys, but you don't know this situation.
Yeah.
Anything can happen. Okay. Take care of yourselves. Be safe, and let's see how it goes.
Thank you, sir, for coming.
I'm sorry, Anisha ma'am. Thank you. Thank you.
Thank you, Dr. Dhume. Thank you very much.
Pawan, सबको वो करो, mute करो.
Yes, sir.
We go online in 1 minute.
Yeah, everybody is muted. So those who want to speak can unmute themselves.
मेरे को co-host बना दो.
Yes, sir. Yes, sir. I'm making you both co-host.
1 minute. Hello. Hello.
Jawar sir, good evening.
Good evening. Pranam.
Namaskar.
Pranam.
Pawan,
Yes, sir.
it's 8 o'clock.
Yes,
Go
we can
online,
start, sir. Yes, sir. We can start,
Please.
and we are starting with more than 125 audience.
Yes.
No problem. You give your screen sharing, first slide.
Sure, sir.
Alim, you'll introduce Tufan, sir.
Good evening, everyone. Welcome to the 6th edition of Thursday Musings. My honor to introduce Dr. Tufan Pati sir. He is from Qatar. He has been a National Advisory Board member, IAPP, Chairman, Membership Subcommittee, IPS, Life Fellow of IIOPM UK. He has organized ANSIP's twice, ANCI, APP, NCA, IPI, and NCI ASP. Formerly, he has been Vice Chairman, IAPP, President, IPS, East Zone and Odisha, editor of Industrial Psychiatry Journal. He has chaired various committees in IPS, IVP, and ISP at various times. A life fellow of many prominent organizations like IPS, IVP, and he has delivered a number of lectures, presentations in national, international psychiatric conference, winner of Madhu Swabiman and 4 Avenues of Service Awards. Sir, over to you, Tufan Pati sir. Please take over the session. Thank you.
Thank you. Thank you very much, Alim, for your kind introduction. I take this opportunity to welcome all present here, and we have got around 400 registrations who will be joining very soon. I welcome Dr. Anisha Shah. I welcome the chairpersons. It is unfortunate that Dr. Bhume had to leave because his wife has tested positive. And we had chairpersons from two beautiful places, Goa and Srinagar. Dr. Majid is there. Majid Bhai will take care of the whole session. I wish him good luck. And on this occasion, National Just Because Day. Today is the National Just Because Day. And on National Just Because Day, we have chosen this topic just because we think it is relevant and very important in current setup. And we have got a erudite speaker in the form of Dr. Shah. And may I introduce our moderators briefly, please share. Pawan, please share. Dr. Alim Siddiqui, who has introduced me. Both our moderators are very brilliant, very young, and the future of Indian Psychiatric Society, as well as the Academy of Psychiatry in India. Alim Siddiqui from Lucknow is the director of Healthy Minds Neuropsychiatry and Behavioral Science Center, Lucknow. He is a visiting professor of psychiatry in Niras Lucknow Medical College and Hospital. He is a direct council member of IPS. He is guest faculty in Amity University. He is finance secretary of IMA Lucknow and finance secretary of IAPP UK and UK Uttarakhand chapter. And now we have with us Dr. Amrit Patajoshi. Next slide, please. Amrit Patajoshi is from Bhubaneswar. We work in the same medical college, high-tech medical college. He is a neuropsychiatrist, psychotherapist, and wellness consultant. And is professor and chief consultant neuropsychiatrist in our college. He is a direct council member of IPS2. He is the editor of Odisha Journal of Psychiatry, which is indexed. And he is the chief coordinator of UNICEF, WHO, an IPS initiative on telemedicine and psychosocial management. And he is the coordinator of today's deliberation, today's discussion session, which is going to be very much interesting. And now I have the pleasure to introduce our chairpersons. Next slide, please. Dr. Dhume, Rajesh Dhume, a very old friend of mine, very good friend of mine who has left. I'm very sorry that he is not here, and I wish all of you join with me to pray for the best for his wife and for him too. He's a senior psychiatrist in Goa. He's a nodal officer of DMHP Drug Treatment Program. He's a member of Government Goa Mental Health Task Force. He's a co-chair of IPS Task Force of Physical Therapy. He's the co-chair of IPS Subcommittee on NGO and Carer. And he co-chair of IPS Subcommittee on NGO and Carers in 2019 and 20. He's past president of IPS Western Branch 1819, past secretary of IPS Western Branch 1214. He's the national teacher of teachers on suicide prevention, addiction medicine for the government of India. He's a GK alumni of 2005. And we have with us, welcome. Next one, please. We have with us Dr. Abdul Majid from Srinagar, the Paradise on Earth, and Angel from the Paradise on Earth. He is currently working as Associate Professor of SKMS Medical College, Srinagar, Honorary General Secretary of IPS North Zone, is Honorary General Secretary of IAGMH, the Direct Council Member of IPS. He is member of World Psychiatric Association, Addiction Psychiatry Section, WPA, the International Fellowship of American Psychiatric Association, many national and international papers, including book chapters, within research work in many national and international forums, has been collaborating research work with researchers of various prestigious institutions like Douglas University, Canada, PGI, Chandigarh, AIMS, and he has received many awards. He received the National Award for Excellence in Mental Health, Glory of India Award, and the Rashtriya Gaurav Award. With this, I present before you Dr. Abdul Majid. Majid भाई, आप ये session आपका है, आप take over कर लो, and the session starts.
Thank you very much, IPS Odisha branch. There is our esteemed senior faculty, Dr. Tufan Pati, Dr. Amrit, my dear friend, Dr. Alim, a dear friend again, both the stalwarts of Indian psychiatry, and the best of the faculty. I can see Dr. Tufan is there who can guide us. Actually, I have been given the opportunity. It's an honor for me, actually. We had a co-chairperson who would share the dice with me, Dr. Rajesh Dome, again, a very good friend of ours, all of us. But unfortunately, because of some personal reasons, he could not continue with us. Any case, the topic today is about couple therapy, and we understand life is a journey. And most of us, the middle class, travel our journey in our cars, and we understand we get a new car, be it it was Maruti 800, now it is Alto 800, or be it Mercedes Benz, or be it Audi. So once you get it to your house, and you initially feel that it should not get a scratch, and whenever it gets a scratch, you quickly go and try to rectify it. It gets it, so you make it sure that it gets a proper service at regular intervals. So that is how this partnership works before marriage. But after marriage, it changes, and you have your better half on the other side. So that better half on the other side, you always feel, and she always needs you, or he always needs you. For females, the husband is always needed, and for the husband, wife is always needed. You have a small scratch, you need to each other's attend each other's scratch, and at times you feel that this scratch may go off its own. It does not happen, and you may need a professional intervention. For that professional intervention, we have none other than a very versatile and a very senior person who has worked a lot, almost 3 decades. I was reading her profile. I have talked to her today for the first time, and it's always pleasure to learn the way of life, actually, couple therapy or any psychotherapeutic intervention, remodeling our lives where there are conflicts, and you try to identify conflicts, then resolve them. So I won't take much time and won't come between you and Madam Anisha. I would just like to introduce briefly, although she has a long introduction, but I would like to highlight certain of her achievements. She is a former head of the Department of Clinical Psychology of NIMHANS, Bangalore, one of the prestigious institutes, not only of India, but I would say of Asia. She has done her MA Psychology from Delhi University in 1984, and she is a recipient of gold medal once she qualified her MPhil in Medical and Social Psychology from NIMHANS in 1986. She did her PhD with her thesis topic, Assessment of Marital Life from NIMHANS in 1992. She continues to be Professor of Clinical Psychology since 2009. She has been a consultant in adult and family therapy facility for a long period. It's almost around 25 years, and exclusively in family therapy for almost a decade now. She has contributed to IGNO courses, particularly on MSc in counseling and family therapy. She has developed a 6-month course for child, adolescent, and family therapy for clinical psychologists at NIMHANS. She heads the marital enrichment services along with family therapy. She is the author of Marital Therapy Scale. Second slide, please. Awards to her credit are GC Boral Award, Travel Grant Award from Swedish Family Therapy Association during 2000. It was in 2000, year 2000. Scholarship for World Family Therapy Congress at Brazil in 2001, and the prestigious H.N. Murthy Oration Award of Indian Association of Clinical Psychology. She has in numerous presentations, more than 120 in national and international conference and workshops. And her area of interest are gender mental health, psychological assessment, marital relationship and therapy, new therapy model, combined couple therapy, emotion-focused therapy, core conflictual relationship theme, training aspects, etc. She's member of a lot of prestigious societies in and outside India. For Society of Exploration of Psychotherapy Integration, International Society for Emotion-Focused Therapy, American Psychological Association International Affiliate, American Psychological Association division member and scholar of various sections. International Family Therapy Association and International Family Therapy Trainers Association. And she is fellow of Indian Association of Clinical Psychologists, Indian Association of Social Psychiatry, and World Association of Psychosocial Rehabilitation. So presenting before one of the most senior, I would say, I have heard for the first time with 30 years of experience in marital therapy and couple therapy, Professor Anisha ma'am, please, can you go ahead with your presentation?
Thank you, Dr. Majid. Thank you so much for your kind words. Good evening, everybody, and welcome to this program. I'm very grateful to IPS Odisha State for organizing this. I'm very grateful to all the organizing committee members who work so hard to let me know that, something from my side is needed in this particular group. So without wasting any more time, I would like to start off my presentation. I'm doing screen share, so just confirm if you're seeing that. Are you able to see?
Yes, ma'am.
Perfect, ma'am.
Yes, 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 perfect.
So I'm hoping that
Rest all mute yourself, please.
I'm hoping that perhaps there are one or two things about couple therapy that I know. And I'm hoping that I can share that with you and that some of it will be useful in the clinical setting, in the challenges that we face, and in the kind of needs that our population has from our profession. As you all perhaps are aware, couple therapy originally was called marital therapy. And over decades of work in this area, what has come about is there is no single couple therapy or marital therapy. It's marital psychotherapies or couple psychotherapies. There are a variety of models that exist, but for the sake of simplicity, I'm going to refer to it as couple therapy, but I'm talking in the context of couples, married couples, and their issues. So what I'm looking at, what I'm presenting here is not applicable for other cohabitating couples. For that, we have to work with different kind of material. It is also not applicable for LGBTQ same-sex couples, etc. I'm just trying to go to the next slide. Yes. Now, this is a very simple kind of table that gives the perspective of traditional models of couple therapy. I'm just showing it here to illustrate that theories or concepts are very important when we are doing couple work. Not because we need to understand all theories and concepts, but because we must know what we are using. So what we have, this is very simple. I think all of you are very familiar with this. What we have is psychodynamic at one end, psychodynamic approaches in couple therapy at one end, and behavioral marital therapy or behavioral therapy, cognitive behavioral couple therapy at the other end. Now, what I'm going to be referring to is largely towards the right side of the table, that is behavioral couple therapy, cognitive behavioral approaches, and how some of the principles from there we can utilize in the context of dealing with couple conflicts. The things about psychodynamic, what newer models have come up, emotion-focused therapy, etc., those can be left for later discussion or for cases or situations when one is seeing couples for long periods of time. But by and large, I'm referring to situations where we are working with couples in a brief format and within the context of many other clinical services. And in that context, what kind of couple work can be activated? These are just names of people who are associated with different kinds of couple therapy theories. So I'm just presenting this here. So in case people want to read up more material on any of these theories or concepts, you can look for these names. At a very basic level, one name that you can also try and remember is the name of Alan Gurman. Alan Gurman is a psychiatrist, and a lot of his basic material and books are freely available on the net as well. And very basic, simple material on a variety of situations in couple therapy context. So you might find that very useful if you want to refer to any basic material. Now here I'm going to simplify a few points from research so that when we look at what we should expect in couple sessions, we have some kind of understanding of what is normal in the context of couple therapy as we progress in the session and across sessions. Now, outcome research on couple therapy has shown that husbands and wives have different rates of improvements. We must remember this. This is very important in the therapist or the clinician's expectations of improvements of the sessions. Also, we know that behavioral couple therapy and emotion-focused couple therapy, these have been proved as efficacious from research studies, outcome research studies. We also have evidence that behavioral couple therapy is more of a short-term therapy which will bring about gains in a short period of time. Long-term gains from that are sometimes questionable and evidence is still being gathered for that. Emotion-focused and insight-oriented therapies have long-term gains and long-term benefits. Quite often, what we do over here in the Indian context, what we have found is integration of these models or concepts. An integration from moving from behavioral and cognitive towards more complicated in a sequential style. If that is done by the clinician or the therapist, that can bring about a lot of benefit. We also have evidence that not all couples improve with couple therapy. Half the number of couples show clinically significant change with couple therapy. So the therapist needs to be aware that not everybody is going to benefit from the sessions and over sessions to be able to have some index through which one can monitor the improvement and take a decision about whether couple therapy sessions need to continue or need to be discontinued. There is evidence about dropouts. Now, a lot of dropouts have been linked with intake by male clinicians. Actually, I should not be presenting that point here because I don't believe that evidence is relevant in our kind of a context. Basically, in the Western literature, in research on psychotherapy and intakes and therapists and gender, they have actually targeted male clinicians and male therapists quite a lot. Whereas in my setting or in an Indian setting, I don't think many of the qualities that they identify gender-linked aspects of therapy are so relevant in the Indian context. But we also know that when couples are presenting with family problems or individual problems, but we try to convert it into couple therapy sessions, the likelihood of their remaining in therapy or wanting conjoined sessions, that likelihood goes down. Quite often, if they are not motivated for therapy, but they are asked by somebody else to go for therapy. So quite often, if it is just the clinician who's referring, or if family members are also pushing and referring them to go for therapy, if they don't have internal motivation for therapy, most likely the therapy will not progress. A lot of it is also dependent on the therapist's joining skills, that is, in what way the conjoined sessions that the therapist holds with the couple, in what way you make that session work. So a lot of points that I'll cover in subsequent parts will be about this particular skill. Process research on couple therapy has shown that therapeutic alliance, the tasks, the bonds, and the goals, which are basically the expectations of the clients, they are more important, not the therapist. Therapeutic alliance has been studied from all angles, from the therapist perspective also, as well as client perspective. It's very common to have different therapeutic alliance experiences by the two persons. That is not critical in the outcome of couple therapy. What is critical is the experience of the client and the client's experience of bonds, tasks, and goals in the sessions. Okay, and these have a continuous kind of a flow in the therapy session. These are not one-time static phenomena. They flow across the sessions in different ways. At all points of time, all three don't have to be that relevant. You can, as a therapist, one can decide in which way which aspect you can hold on to even while there is a negotiation going on the goals or the task, how the bond can be still preserved. So many of these qualities create a effective therapy session. The client's acceptance of the treatment model has a very important impact on the outcome of couple therapy. Similarly, the client's ability to perceive the therapist as competent and concerned, and to be able to see that there is a flexibility in the way the therapist is doing the work. It is not a very rigid model that the therapist is applying. Also, the therapist's ability to improve communication between the couple. These kind of processes, when they are created in the couple therapy sessions, they have relevance to the positive outcome at the end of couple therapy. These are all evidences from process researches in couple therapy. Irrespective of the kind of technique being used in couple therapy, the emotional relationship, if that change is facilitated by the therapy sessions, again, that brings about an overall positive outcome on a variety of measures. So in a nutshell, what the research from process studies is telling us, if you look at the components of therapy as affect behavior and cognition, if at least on 2 of these 3 aspects, the processes in the therapy are addressing these, most likely the outcome can be positive. Now I'm going to come to the context of our setting, the Indian setting, the context of couple therapy here, how can we do sessions here, what is all this about? So I'm calling this, the kind of work that we need to do here, I'm calling it somewhat a term like this: ecologically or culturally relevant couple therapy is what we need to do. Ecologically, basically I want to say ecosystem in which the couple is existing is critical in even deciding how to go about the couple therapy. So what is this ecosystem that I'm referring to? The realities of our setting are quite complex. So as I said initially itself, we are looking at married couples situation over here. If we have to look at cohabitating couples or same-sex couples, we'll have to look at many other approaches. Now, we also see couples with or without psychiatric disorders in either partner. It's very common, it's increasing. Number of people who are wanting to reach out to a mental health professional for couple sessions is increasing day by day. One of the things I keep telling my students regularly is that in their professional career, they're going to see more and more demand from couple therapy, context than any other type of psychotherapy. And I was surprised to see that this is not just my impression from India. This is being talked about in other countries also. That couple therapy is the highest, it's most progress is going to be required in this particular domain in the coming decades because of the complexities, because of the importance of this intimate relationship, and because of the relevance it has on a whole lot of aspects of life. Most often, we as clinicians in our, trained professionals are likely to come across moderate or severe marital discord. You are unlikely to see mild marital discord. There are many other people in the community when for mild marital discord, they approach them. They go to lay counselors, they go to anybody who is a counselor, they go for 1 or 2 single sessions here and there. They may go for some group sessions. They may often go to many of the corporate world sectors have certain programs which are designed for improvements and growth and relationships and all that. And you may often find that people have gone through many of those things. And so the history of conflict would be a lot more. And at some point of time, people often realize that they require something a little more intense, a little more deep, a little more professional, a little more scientific. And that is where they turn towards mental health professionals who are qualified professionals. Quite often, you may find that in a variety of settings, I'm assuming some of you are in private practice, some of you are in hospitals, in different kind of a setups. So you may come across cases sometimes when it's your very first contact. The very first time the person is coming with the partner and seeking some help or some opinion. Or you may come across situation where you've been seeing the patient for a long period of time for psychiatric issues, for treatments. And as part of ongoing treatments and all, and follow-ups, you may recognize that there are some other factors that are happening in the context of the relationship. And so couple work is required, or the patient is complaining about the spouse repeatedly, so you request the spouse to come in, or many situations like that. So these two different kind of a context can be looked at slightly differently. I'll come to that a little later on. Okay. It's also common to have history of previous consultations for marital as well as individual issues. And quite often, even when they approach mental health professionals, they may still not reveal to you how many other, they may not be hiding deliberately, but they may not consider it relevant. But a lot of times, people would have taken many other consultations of many other types, sometimes simultaneously while they are taking help from a mental health professional for some psychiatric issues. And quite often when you want to do therapeutic kind of work with a couple, it might be important to pay attention to that history, to understand if concurrent sessions are going on even now. And quite often, even in our setting, we find that there are concurrent sessions happening in a private setup with somebody else and something else from NIMHANS and things like that. So this seems to be the way in which the population is moving. And we need to figure out in which way our intervention can still become something that is relevant for them, and at the same time does not add to the confusion that they are getting, from multiple sources that are providing intervention simultaneously. We also have to remember that there will be involvement of many other people in the couple conflict. Even if they have not taken formal help from somewhere, there'll be some family members, some friends, some people, some child, somebody would be involved in their matters for some period of time or the other. The conflict between the couple, very rare cases you find, is just completely hidden between the two of them. Sometimes you'll find that in mild kind of cases where they otherwise would be, perhaps they would have negotiated many other things properly. We see those kind of cases in our marital enrichment center, where outwardly otherwise everybody is seeing everything to be all right, but at an inner level, intrapsychic level and a very intimate relationship level, they are experiencing difficulties and all. But that is not such a very, not a very common kind of experience. More often than not, family members would be involved, some sibling would be involved. Even when they are coming and talking to you, somebody would have encouraged them or guided them to say, you tell your professional, tell your consultant that you want to talk about this or want to talk about that. And so it is important to understand what role these factors are playing in the way they are seeking help now as a couple, or they are wanting to talk about relationship issues now. These factors, all these factors together influence the way in which we can proceed in therapy. That is why there is no textbook application of couple therapy in our context. Now, the core of the session that we are doing, we must create the aim of the session as to empower the couple relationship. That is the core of it. The core of it is to assume, not to take on a deficit model, that one individual is having this problem, other individual is having that problem, but to assume that no matter what details you obtain, especially I'm talking in the context of brief sessions work. In brief sessions work, one needs to have a very disciplined approach towards their content. So the goal of the inner goal of the clinician or the therapist needs to be that somehow or the other I have to find some way in which this couple can become stronger, become more resilient, or develop better skills in negotiating their difficulties with each other or with other things around themselves in their system. So the principles that I'm focusing on, which I said are coming from the behavioral and cognitive behavioral perspective, these go in that direction, that this is about basically no matter what the therapist is doing, we keep the emphasis on how this couple within short period of time, within a few visits, feels that they can handle or talk to each other a little better, or they can solve their difficulties a little better, or they can turn to each other rather than to the therapist for solving the difficulties. We also know that in our context, especially, you will find it's very common for parents to be involved in couples issues. We call it family of origin factors, FOO. FOO is a very important aspect in our routine family therapy training, but to simplify it, we do it in a very intense way as part of the training. But basically, it is that you must pay attention to what role each family of origin of each partner is playing and has been playing, especially in the recent past, and in the context of conflict and in the context of giving support to them. In what way are they relevant? Don't move them away quickly. A very typical mechanism, very typical observation can be they're intruding, but quite often you can't be very certain early on. So it is carefully understand that quite often that kind of engagement and support is relevant for the couple, and we can help them retain that, retain the good intentions of the family of origin persons, and at the same time, in their own way, without humiliating anybody, how they can improve their boundaries with them, that can be worked on little later on. So it's very important not to judge them. Okay. We also know it's very common to have couple conflict existing in the context of very severe chronic childhood difficulties, young adults with long histories. In many of those contexts, you'll find long-standing marital conflict may be existing in the parents and may have been very much part of the history, part of all the records that have been kept, but nothing has been done about it. And you'll be surprised that earlier, maybe 20 years ago or so, we would often define, even in our researches, we would say upper age limit 45. Now you will find even couples in their 50s and 60s and 70s are wanting to come and sit in couple sessions to sort out the issues, or to improve their view of life, the way things happen in their families, in the way they look at each other now. So it's very important to remember and to develop some kind of a skill for working with even people in all kinds of age group, couples in all age groups, and not go with only the fact that the focus needs to be only on the index patient. We also need to respect the family background and the relationship, everything. Now, respect is very easy to say, but to actually live that in the sessions with the couples is not very easy. So because we are used to pathology model, we are used to seeing problems, we are used to identifying difficulties, we are used to identifying vulnerability factors. Because of that, quite often, we don't notice what they actually are, what is their identity, what aspects of their life they negotiated in a unique way, and how to keep that in place. So that quality and that particular attitude needs to be cultivated. So it is important that if you want to do couple work, at least some segment in the session is kind of demarcated as a session where you will not allow your mind to activate the psychopathology model or the vulnerability model. That you will try to understand them the way they have been, the two people, their backgrounds, the kind of ideas, values, notions that guided them in their family life and the way they came about. Try to know them and appreciate that or respect it, not be judgmental on every aspect of their situation. Now, it's also important to drop the causality model. This is perhaps the most important point, and perhaps the only point that I have to say over here in this presentation. Basically, that we activate causality approach very quickly. Quite often, referrals for couple therapy or family therapy also happen, because of a causality approach of the clinician or the mental health professional, which is basically you're saying this is causing the problem in the treatment of the child, or parents' relationship, or parents' style of talking, or parents' fights are contributing to this. So they are the cause of the problem, and so we need to do therapy for that. Now, what happens is in a relationship therapy based approaches like couple therapy and family therapy, the causality perspective has to be thrown away completely. What we have to narrow down is on maintaining factors. And there are a string of maintaining factors that you will find if you practice and you search for it in the cases that you come across. You will find that there are a string of maintaining factors. And they feed each other. It's not any one thing that's causing the other thing. It is a complex set of factors that are coexisting. Some happened at a certain point in time, so it influenced something else. It changed some aspect of the relationship. Then something normal happened for the family. It changed something else further. Then something unusual happened to the family, or challenge happened to the family, and it changed them even further. So how things happen, in a way, maintaining factors redistribute responsibility a little bit. So in a way, most family therapists would believe that it's a good thing, except in certain situations. For example, in the context of violence, where individuals have to take responsibility, in those situations, we don't weaken the sense of responsibility. Okay, so otherwise, by and large, typical conflicts in relationships, this approach is very useful. And the way the session is conducted by the therapist, when the search is for these kind of material, this perspective goes across to the couple also. So it helps them see themselves differently. This change is very critical for helping them feel optimistic about themselves, not feel blamed, feel comfortable and safe in the sessions, and with that to move to discover changes in themselves and even be helpful to the partner for making changes. Now, next point is about weakening the symptom or the disease perspective. We call it decrease patienthood. In quotes, we call it decrease patienthood in the session. So we know it's a mental health setup. So most people, when they come, they talk about symptoms, problems, history of the patient's illness or difficulties. And so everything is with reference to the patient's symptoms. So spontaneously, the family members often talk about that. But in order to progress on couple therapy perspective, the clarification questions that the clinician or the therapist can use, if they are not about the symptom, if you're done with that, you don't have to have any more knowledge about the symptom or the disorder, those treatments are in place. Avoid clarification questions on that. Frame clarification questions on the relationship, on the interaction between them, on the interaction between family members, on specific situations and contexts when this is happening, how it evolves, how it ends, without asking how do you cope with it. So a generic question can be avoided. The questions can be made more specific, and that is again another important point that I wanted to highlight over here. Now, whenever material comes up, whether spontaneously or based on your clarification, have the discipline of not activating personality theories as well. Not just the psychiatric classificator system or the disease model or psychopathology model. Do not activate personality theories as well. Do not allow that to influence your questions. Okay. Now, often you will feel pressure to do that because of the way they are also talking. And they hold those models. Couple will be holding those models. But we don't have to work on that. There is no couple therapy which is based on understanding. There's no specific personality theory that is used by all these couple therapists who have worked for decades and decades on couple therapy. No specific personality theory has been useful for understanding couple therapy perspective or for creating the foundation of couple therapy. So it's very important to have that as another discipline. Now, personality traits are often there in individuals. So one of the things I've trained myself, and I train as many people as possible on this also, is to keep telling people, couples, and even I tell the trainees also, that people are of different type, or everybody has certain styles, everybody has certain habits, everybody has certain, in some aspects people are a little rigid, in some aspects they are a little flexible. Sometimes some people become more rigid about something or the other. Sometimes you become rigid because of certain factors. Sometimes you become like that just because upbringing has been like that. Now, in the context of the couple relationship, let us find out what you wish to change. So let us not use the label of any personality disorder or a personality problem, but let us find out what you wish to change, what you wish to keep about yourself. And quite often we have found over years and years of work with a variety of populations that we see that are referred to us, we have found that many couples where there would be one partner with a little bit of personality vulnerability, when couple therapy work progresses well, makes the person feel safe, then that person is willing to go for more individual therapy. When no longer the partner is attacking the person for one's style or one's limitations, then they feel safe enough, then they are willing to take more help for themselves or their situations or their styles or their symptoms. So now let me narrow down things a little further. Let's imagine that in the first half of a visit that you have from a couple, what kind of attitude and what kind of things you can keep in mind. One is remain curious. Remain curious about them. Don't believe that you know them. Even if you have seen somebody for a long period of time and one index patient has been coming and for almost every aspect of their lives in this story you know, still don't believe that you know everything. And why this curiosity? Actually, in family therapy research, curiosity has been identified as one of the best skills of a family therapist. That without this skill, a family therapist can't become good family therapists, even if you have techniques and models and practices of many of these. Pay attention to facts. Now, what we believe is that what people actually do, how actually things evolve, tell you a lot more about them and their relationship and their difficulties and the places where they need to be helped, rather than just their opinions or impressions or their abstract ideas or inner experiences. So people usually will start telling you by inner experiences. Your questions can move towards facts. So easiest way to go in that direction from spontaneous disclosures is to start saying, give me an example of what are you referring to? Illustrate to me, for example, in last week or last month, what are you referring to when you experience something like this? And in that, go into details. Details are specific details about what time of the day was it happening, who all were there, what did you say at then what happened, how did you come to know this? So we call all these things circular questions. And it is through this sequence that you unravel about specific situations and examples that you can understand many aspects about what's actually going on in their relationship. Now, each partner should be given equal time while doing this, without wanting to reach a sense of complete understanding. You don't have to say, I've understood everything about the situation. You say, I got some idea about this. I got some idea about how it was for you. Now I want to know how it was from your point of view. So if you don't mind, I'll move to your husband or your wife now to see what you recollect about that event. Start from scratch. Don't frame a question for the other partner based on one phrase or one word or one accusation of this partner. If you do that, it takes away the alliance, it takes away the neutrality. So those are the subtle aspects of how we speak, how we ask things in the sessions that make a difference to a couple session. That is where conjoined sessions are beneficial. Okay, so asking for examples is a very easy method of eliciting facts, data of recent past, recent incidents, examples of a variety of situations that will tell you, that will show to you how flexible they can be or how rigid can they be, how well can they resolve certain difficulties, which situations they do better, which situations they do worse. And it is that kind of a specific knowledge that can help her as a therapist. So these kind of things, like with little bit of expertise, little bit of experience, one can achieve some of these things in first 20 minutes of the session. And most often couples do want that. Couples don't want session after session to just come and tell you details after details. Many times when they experience those kind of sessions, they know they are telling all the stories, all the facts about their lives, but they don't get to hear the therapist. For 4 or 5 hours, they've come and told all the details about their families and this and that, but they don't hear a word from the therapist. So that becomes, it makes them very nervous. And couple therapy basically is most effective with a very high activity level of the therapist. This is again found from research. A very high activity of the therapist. We don't have to dance, but we have to make sure that every other minute you are saying something, you're saying something specific. You're combining questions and statements, not just questions alone. Not questions as if you're not there, you're just wanting to know their background. It's not about that. So your presence as a therapist needs to be revealed in the statements that you're making. Your style of thinking also needs to be revealed with them. Quite often, I suggest, even before knowing a couple properly, if you know that they are seeking straight away for couple therapy session, even it's all right to make statements like, usually in couple therapy work, it is useful to not take anybody's side. It is useful to not judge anybody, and that's the kind of work I would like to do with you. And so I would like to hear each person's version, each person's view of things. Differences are common in couples context. My job here would be to help you understand those differences. Differences are not the end of your world, and how you can make this work for you despite the differences. What kind of changes are required for that? I'm here to help you find that, so that you don't have to go to a therapist every time you have differences or every time you're stuck with a problem. So it's quite useful to say something like that even in the beginning, even before you know them. And you can still say it tentatively. You can say it like, these are general kind of principles that we usually like to follow in couple therapy. Anything else that would be required for you as we go along, as I understand your situation better, I will see in what, if I have other ideas, I can share it with you. As we go along, I'll share those with you. So the role of the therapist, the position of the therapist is articulated. And a lot of that kind of communication is so comforting for them. That is more powerful than any kind of a technique that you're going to do. Okay? So using many of these things, you can constantly reset the goal. Goals are not etched in stone. Goals can be evolved. They can be very transient. They can change across sessions. You show that flexibility and you show your competence to be able to work with it. And at the same time, keep the therapy at a sensible level so that there are no unrealistic expectations. Couples will respect you a lot for that. And even if they are not the presenting problem for which they have come, even if that is not completely addressed in the session content, it's very common for couples to just pick up some of these styles from the therapist and not want to have any more sessions after even 4-5 visits. And we have had that evidence very strongly that the kind of what we would otherwise technically call dropouts are not dropouts. People have come back to us later on and said after 3-4 sessions we got an idea, and then though we are sorry we didn't tell that we won't come, but things were kind of working out and we knew what we need to do. So, but now it's a different context for which we want your opinion. So many times people come back later on, and that is the kind of contact that is revealed to us. In some of the researches also we have found there is something called intent to treat group. Intent to treat group will stop having sessions after 4 or 5 sessions, and they still report some kind of improvement on this and that. How does that happen? It happens because of perhaps these kind of factors, these kind of processes to which they get some kind of exposure in the therapies with the therapist, and they pick up that idea of to look at themselves in a systemic fashion, to not be blaming each other, to be able to see things that they have resources to work on and use that as a means of going forward in life. These are various ways in which material can be organized, but it's also, I don't want to go into too much of details here, but I just want to emphasize that a typical couple therapist doesn't necessarily have to do very long history. In our training context, because these are young trainees and very young mental health professionals, we emphasize on that. But by and large, a practiced, experienced clinician doesn't have to necessarily always trace everything backwards in a very systematic fashion. Whatever spontaneous material you get from them, you can just organize it using some of these ideas and keep some kind of a map with you about it, so that you have some adequate information. If on some aspect you have a little doubt, you can add a few clarification questions on that and then proceed for some minimal assessment and again go into some kind of a tentative intervention. Circular questions I already mentioned. They need to be framed sensitively, ensuring that neither is blamed or attacked, and should reveal your curiosity as well as your neutrality. Okay, so these can be framed about sequence of interactions, the context in which interaction is occurring, specific cognitions, emotions, behaviors with respect to those specific events and with respect to each other. When did you come to know that she was feeling like this? Is a specific circular question. After that happened, how did you come to know, or when did you come to know that she was upset about that? What did she say at that time? Who told? What time of the day was it? So like that, to understand the connections between things in specific way, that kind of material can lead you to what I'm emphasizing on. The intervention that you can do can be designed on communication, and from cognitive behavioral perspective, we'll narrow down on attribution. Okay. Now, relationship attribution is again it's a very simple perspective actually. And this is something that we, in international research, it's not emphasized so much. But in our work here, we find, especially in my practice and in my training, I find that's one of the most easiest way in which we can work with couples when we can't improve behaviors quickly. Communication work is also about behaviors. So sometimes you can start on that. One second, I think I need to charge my laptop. One second. Yeah, so what happens is there are couples who can move on to the behavioral changes when you start talking about communication work with them. Most of the material that you would have understood about them with specific situations, you can very easily formulate it around changes in communication between the two of them, making communication more verbal, less use of nonverbal, not assuming things about each other, using I statements, not using labels for each other, not using shoulds and musts. These are all very basic aspects of communication training that can be relevant for couples. But quite often, they don't move very quickly on behavioral changes. Now, when they move quickly on behavioral aspects, that's a good sign. So it's a good thing as a therapist to try moving on behavioral changes. Because if people are able to be flexible in behaviors, at least they try. If they are not fully successful or it doesn't take care of all the problems, that's all right. But if they are flexible to give it a try, it does suggest that the change in emotion and change in belief is happening simultaneously. It's understood, it's implicit. But sometimes they find it hard. They'll do a little bit in the session, but if you probe the impact of that or whether it stayed with them later on, you may find that they are already in some other frame. They don't even remember what they talked about in the session. So the approach from cognitive behavior couple therapy, let's narrow down on attribution aspect of it. You know many other aspects of cognitive behavior couple therapy. They can also be utilized over here, but I don't need to go into that. Let's look at the attribution thing. It is known from research that relationship events, especially negative relationship events, preoccupy couples a lot. And actually, there's a very simple measure. It's called marital attitude survey. You can look up that if you want, but it's not very popular in research right now. It used to be in 80s and 90s. But the dimensions of that, I find that just remembering those dimensions and using that to understand a couple from an attribution perspective is useful. It's good enough. So the dimensions of that are, of course, two dimensions are about their expectation of change, that yes, we can change, yes, a relationship can improve. Couples vary on that. So some very extreme couples you might find are completely given up on relationship and they're most reluctant to even seek therapy. Both persons. It's very common for one person to not be willing and the other person to be willing. So that doesn't go in that category. Those can be worked out in therapy. But the important aspects are attribution of negative events to own behavior, to own personality, to spouse's behavior, or to spouse's personality. So these four aspects, if you tease out the material that you've got from them into that to understand what they seem to be doing about each other's behaviors and about their own behavior, and that is where you can narrow down on creating some kind of a change and helping them reattribute things to, because it's very well known that negative things are seen as unchangeable, are seen as very stable, very chronic, whereas positive things are not attended to at all. So in reattribution work, the therapist can help them start seeing in which way what is happening right now is not just about the person's personality or unchangeable aspect, to show in which way those are aspects that are changeable, and by the participation of the partner in the session also that will provide evidence to this person that yes, this is an changeable quality, it's not unchangeable, it's not fixed in time. So these two components, if one focuses on, it can perhaps be quite beneficial for a lot of couples, and they'll take something new from you from the session and be able to find something that can bring about some kind of a change in the interactions that they are having. Now, what is important is, as a therapist, that the facts or the data that you've got from them, you make use of that in this kind of a disciplined fashion in the second part of the session. So that discipline has to be built up. You need some concepts to build it up. Without concepts or theories, it's very hard. We'll be going all over the place. We'll try to address every aspect or every situation that they have raised. But to narrow it down and to present it back to them in the second part of the session. In many of, in one of our settings, the marital enrichment setting, quite often what we do is 20 minutes, half an hour with the couple to let them speak and in that context to get information and all that, and give them a break. Therapists, if these are young therapists who are not used to this kind of work also, they also take a break. And during that time, either we discuss together, or the therapist spends time to organize the thoughts that, how this material can be put back now for this second part of the session. Call them back in, and then present the agenda or the goals for the remaining part of the session, and the way the subsequent sessions or visits can happen or not happen or whatever, and then make them work on it, so that end of the session, end of the visit, when they're going back, there's a tangible thing that they have got from the therapist, and there is no need to guarantee that that is the final ultimate solution or intervention for them. It is still presented tentatively, what we call one down position. And with that, they are encouraged to see, you give it a try, and how much time do you need to give it a try? Let them decide. They say 1 week, 2 weeks, no, I'm traveling, no, I have work, no, I have this, that. Let them decide. You don't decide. So the Western typical format we read in books is call them every week. Very often it doesn't work because they have real life situations to deal with. And it's good that they're dealing with real life challenges. We don't want to interrupt that for them to come for the session. So if they say, no, I have work to attend, I have conferences, I have travel, no, I have so-and-so to take for surgery, this, that, tell them that once, if these ideas are useful, you keep it with you. You decide how many weeks you require to give it some kind of a try, give it some thought, bring it into your routine or in your life a little bit. And then you let me know, you visit, you fix your next appointment, you come back, irrespective of whether you've been able to do much or not. When you think you want a review about it, let me know, fix an appointment and come back here. So this is the way in which you try to make it tangible for them. Making statements linking with the specific goals, and even when you know that you're going to narrow down on communication or on correction of attribution, even introducing that will become quite relevant. How am I doing for time?
No, madam, you can continue.
Okay. Okay. So it's very important for the therapist to make very explicit statements, not just about the goals. We often say that the therapist can share the view also, that you can see. If you're not very confident in the very first meeting, you can share more detailed views or your opinion about them a little later on. But hope building statements are very critical in couple therapy as well as in family therapy. Now, very often we do see situations where internally the therapist will not feel so hopeful, because you can see a whole set of complications. You also know the complex history, you know the amount of trauma the family has gone through or things that have happened in the relationship. So internally, it's quite common as mental health professionals to not experience that much of hope, to not feel that they can recover in just 2-3 sessions from everything. But it's important to have realistic hope building statements, to even say things like, some of those things happened then. Right now, I don't know which way we can look at those aspects that happened 10 years ago or 20 years ago. We'll come to that a little slowly, if that's all right with you. But I think some of these things about what happened last week and what's going to happen next week, these aspects I think we can do something about. So how about we spend more time on these things as we go along in the sessions? So constructive hope building statements that are realistic, that are doable, and that are still acknowledging things that they have shared with you. You're not ignoring the difficulties that they have shared, or neither are you telling them straight away, oh, I'm feeling so overwhelmed, you have so many problems, I don't know what I can do about that. So you can't detach from those things. You still have to validate it. You have to give it a external reality for them. That yes, it happened to you. I heard you when you said that these things happened 10 years ago, but they still bother you. Okay? So, but I'm not sure if straight away, if those things I want to talk about in the sessions right now. I thought that, what is going to happen next week regarding this decision or that decision. I thought that might, perhaps we can start there and then go to some of these other things later on. How about that? So you present things tentatively, present flexibly. Always have options ready also. If you wish to have some other things discussed, I can always see you separately as well and see how from those discussions we can bring some of those things back here into these sessions where both of you can work through some of those long-term difficulties as well. So usually some of those mechanisms might be required if you don't know the couple, if neither of them have been with you otherwise beforehand. So sometimes adding some individual sessions in a planned way, not in a way of encouraging secrecy there, but to in a way that, let's talk about that so that I can help you figure out how some of the issues that you don't want to talk about in your husband's presence right now, how you can talk about it here. I can help you get prepared for that or work with that with you in that. Then we can come back in there. So quite often the format of alternating individual session, conjoined sessions will also be quite relevant. So these are just some of the other ways in which we help them start feeling optimistic. Reframe statements. Examples are given over here in some ways, basically. So these are ways in which you help them, you're showing them that I'm not judging that your needs are wrong or your expectations from each other are wrong. All I'm saying is let's find out whether something in the way the needs or expectations are going across to your partner, something about that may be unreasonable. Something makes it appear unreasonable. So let's find out in which way some modifications can help in that. And most often, actually, a lot of couple therapies that I've seen, basically all of it has been about helping them just learn that my spouse is not unreasonable all the time. I start with percentages. I say, do you think all the situations that have happened, what percentage do you think she is reasonable? What percentage do you think she is unreasonable? And when you start helping them or making them quantify that a little bit, and you say, okay, now you're saying that in maybe 5% of the situation she is reasonable, let's start with that. Let's not talk about where she's unreasonable. So we know that when there is depression, there is anxiety, there are other symptoms in one partner or the other. We know that at times they will be coming across in an unreasonable fashion. But we don't make that the focus of the couple session. We say that we'll address separately. If you think she still has more problem and she should be going for therapy, we'll talk about that. If she wants it, she will do that. Same thing if she says his drinking or his alcohol is a problem and that is where everything is wrong. If he wants that help, we can arrange for that. But you've given your opinion to him, but the decision has to be his. So separate out, create that sense of responsibility towards one's symptoms or one's difficulties for each one to be able to respect that. But at the same time, in the conjoined session, let the session be about, let's talk about where you think the other person is correct, not where the other person is wrong. Another aspect is where you think the other person's feelings are wrong. This is again a very big problem in couple relationship. People believe that if a spouse is experiencing some feelings, they want to go on telling the person how that feeling is wrong and how it needs to be replaced because it is wrong feeling. And one very simple method I use with couples is that nobody can judge other person's feelings. Even I can't as a professional. I can't tell either of you that your feeling is wrong. Your feeling is a feeling. You have a right to your feeling. Okay? The point is when that person is going through that feeling, what do you wish to do? What do you wish to do to help your partner? Is there something that is possible? So you can't change the feeling. You can't make a thing differently or you can't make him experience it differently. But can you do something to, these 2 points actually come from EFT, which I use in a very simple fashion. So they're just woven together with the more of this kind of approach. But the point is just this much. If you see somebody feeling anxious, as a spouse, your role can be whether you can reassure that person or comfort that person. Comfort and compassion in actions, in gestures, even making a cup of tea or going and bringing something that the person likes. These can be very simple gestures to create a sense of comfort, a care, a thoughtfulness, or compassion for the partner. In that moment, the struggle to change the partner's whole inner core has to be dropped. So using these kind of very tentative interventions, don't push it too much. Don't expect them, don't convey to them that they're doing something terribly wrong if they're not doing it right now. That's very important. Just insert a little bit here and there and see how it takes, in what way it shows them a different kind of a way of looking at the difficulties. So each one's changes are important. Increasing each person's sense of responsibility towards the changes are important, and create or show them the goals that are changeable, that are achievable. So that is where the principle to start with goals that are tangible and that can be visible in interactions in a few weeks' time, in a month's time, something like that. That will be relevant. In anticipated interactions, changes may be visible or not. That can be relevant. So creating content around that kind of a thing. Reducing threatening gestures, communication, threatening actions in their interaction cycle, that's important. That again, using psychoeducational approach itself, you can reduce it. You don't have to do anything else. So it's not about something that you have to attend too much, but beginning of the session, end of the session, reminders about that. Especially reminders about avoidance cycle. So what happens is, with a long history of conflicts, many times the couples start having avoidance pattern. They say we are not talking to each other for 3 days now. And that's why we have come to you. We'll come to the session and we'll talk. So these have to be, this kind of expectation has to be broken immediately. That couples, there are many couples who will have a conflict, then they'll separate and they won't even meet each other. They'll just be texting and they'll say, we'll come, but we'll come together for the session. And in the session, they want to talk and fight. So that also has to be discouraged. So quite often, I actually don't do conjoined sessions in those contexts. If they are not living together in one place, there's no context for doing conjoined sessions because you can't link it to a system. You can't link it to a set of rules that they can create. So using that 1 hour or 2 hour of therapy as a test to decide or make a decision about the husband or the wife or the relationship is not logical. It's not sensible. And that can be again approached in a psychoeducational stance itself. They can be gently but clearly educated about these aspects. Okay. So we'll go on to the next one. So attributing negative, this part I already mentioned about the attribution component. In what way they can be helped to notice positive events, and even if noticing positive events is hard because of the emotional distress right now, in what way the negative events, what they attribute the negative events to, that can be modified a little bit. And that will go a long way in helping the improve the hope building also for them, and remove the filter of past evidence. So it's not that as a therapist you're saying that you're thinking that this is because of that is not your fault. It's not a flaw in the thinking style. Most people learn from experiences. So you must have seen a lot of experiences which you've put together in a certain way and you've concluded certain things. But now you are in therapy here. So it's not about that in the past it didn't happen or your judgment about the past was wrong. I don't know about that. I'm not there to judge what actually happened in the past and whether your conclusion about that is right or wrong. But today, if you had to see, if you had to feel something different about your relationship, what would you need to see? And will you be able to see it when he is doing it or she is doing it, is the question. So helping them, this again cognitive work, it's coming from that position, but you don't present too many cognitive theory concepts to them. You work with just 1 or 2. It's not easy for people to make things useful for themselves if we give too many aspects. When malicious intent is attributed to the spouse or lack of love is attributed to the spouse, that becomes more difficult. So if you send some of that across few sessions, if you don't know them that well and they've just started coming, but you start sensing something like that is there, then still try conjoined sessions only for some time. And later on, if you find that something is like a very inner kind of a block in one person or the other, add some individual sessions to see in what way. Sometimes what they are experiencing is not wrong. It's not a unreal phenomena. It is part of their lived relationship. You know, sometimes they can sense that the other person is moving away. One person is already withdrawn from the relationship. There is no sense of involvement or commitment any longer. So quite often, some of that might require a different kind of a approach. So those are more complicated kind of a setups. Um, so basically in conjoined session, when new kind of behaviors or new kind of way of looking at each other is encouraged, it's built up, then to help them create a sense out of that together in the session without any one person dominating the session. Okay, we know that in the context of psychiatric symptoms and illnesses, we often know that dominant submissive patterns are very common. They can occur either way, but they are very common. But how to balance it out a little bit more? It's not about very typical equal balance that we'll find between the husband and wife, but the right kind of a balance between them, where both are comfortable. You know, so when both are okay with a certain style in which one person influences something, another person influences something, then it should be all right. So encourage that and encourage them to look at small changes that each one is making, not just oneself, but the partner also, and to be able to give positive feedback about that, to acknowledge that to the partner in the sessions, if not outside the sessions. So last few minutes of the sessions, you usually should try to see if each one can share their view of the session as well. That will inform you a lot about the session and about the kind of plan you can make for the next visit that they will have, because you will know already which aspects are not covered yet, which requires which are a little troublesome. You're also a little worried about it. You can anticipate, you can predict how some of those things will affect their interaction still, and so in what way you need to be prepared for the subsequent visit. Give them additional rationale from your side constantly, that your attempt is to help them find better way of influencing each other so that they can become self-sufficient on relationship matters. Okay, have realistic expectations. So encourage them to understand that just having one meeting will not take care of their 3 years, 5 years, 10 years, or 20 years of marital difficulties. So that's a realistic kind of a vision. So that it's not about covering everything that has happened and that everything will change just because in one moment in the session somebody said this or somebody said that. You say, use the learning theory perspective. You can articulate that and psychoeducate them also about it. That basically many things happen in a certain way between two people where patterns get created. These patterns got created because of the kind of things you learned also. So now some of those things are not working for you very well. So I'm here to see in what way I can help you unlearn some of those things and learn new things. But it calls for some practice, it calls for time, it calls for patience. These things don't happen overnight. So let's have patience. So even if some old patterns come back and some old fights once again get triggered or old problems get triggered, don't lose heart. Okay, still come back for the next visit. Let's see in what way we can get back on track, how we can keep having patience, and how we can continue trying to, both of you can try, not just helping yourself, learn how to help your partner also to make the changes. So it is through this kind of a mechanism that the therapy sessions can end, and there can be some kind of continuity across the sessions on these kind of content. So I think with this, I've come to the end of my presentation. So thank you all. And now back to the moderators. Thank you.
Thank you so much, ma'am. We were all glued to the screen. So
Okay.
it was a wonderful, really nice session. Amit, can we start the questions?
Zim.
Majid bhai?
Majid Bhai, sir, let Majid Bhai start with his observation, then we'll take up the questions. Majid Bhai, unmute, sir.
Just give me a minute, I'll have some water.
Unmute, sir.
Yeah, done. I was muted by the host. Madam is there?
Yeah, just having little water.
Yeah. Please go ahead, ma'am. I understand that it has been more than an hour, and it has been an academic feast, really. At least for me, who is once it comes to psychological intervention, as most of the psychiatrists are, they would agree with me. We are on a weaker wicket once it comes to psychological interventions. So it's always a treat to learn and listen from a learned speaker like you. What I have also observed during these 4 or 5 months of lockdown is that there are issues that have come up, particularly within the couples or within the families, be it what we call vulnerability stress adaptation model. That vulnerability because of the mental health issues in one of the spouses, or medical issues, or stressors, like there are a lot of people who have lost their jobs. Particularly the private sector is in shambles. There are people who have come back from Gulf and other countries in the world staying at home. So the friction has really increased, and financial burden on families is there. And there are only few number of families or the couples who have actually adapted positively to the change, and most of them have been negatively affected. So with these comments, I think you are the best person to respond to in practicality that way what has been happening for last 4 or 5 months, and what it has done to the couples, and what is the role of couple therapy as far as the current scenario is concerned. Back to Dr. Amrit and Dr. Aleem for question answer session, and I would like again to thank all the speaker and all the people around for being there. We had around 350 registrations, and thumbs up to Aleem Bhai and Amrit Bhai and Dr. Tufan. And madam, it has been really enlightening. Over to Dr. Amrit and Dr. Aleem.
I'll take the first question. Madam, one of your friends, batchmate, Mrs. Deepa, she heard you and is congratulating you on a wonderful speech. So I'll come to one of the most important aspects, madam, and that question has been very aptly put by somebody. Pati, patni aur wo. So, one of the commonest reasons why people come to us in our OPDs nowadays is about the woe factor. So when something, like I have a very close friend of mine who was caught speaking I love you to another girl. His wife caught him. And now they're on the verge of a divorce. The girl wants to know about the other girl. As long as he does not disclose about the other girl, she won't come back on the table. So how do we handle this woe situation when it comes? How can we move around that?
That woe situation is very complex, and there is no single mechanism of working with that. We have written a few things about that, about what we call EMI, extramarital involvements, okay? And they are becoming more and more complex nowadays. But we must understand that not everything where EMI is there, not everything is about couple therapy. And not everything is about the couple relationship. There are many other factors that play a role. There are many other social factors, the kind of way in which people look at themselves and their lives, the inner notion that people have about what they would be like in life, whether they would be remaining in a marriage or not, and whether they'll be constantly checking for new partners or not. A lot of that is at a very individual level. So it's very common to have situations like that where somebody has decided that the other third factor is not going to be, that relationship is not going to be ending, and this spouse decides that divorce is the answer. That's fair enough. I don't think there's any problem in that. So it is basically, the idea is no longer it's about just save the notion of marriage. If two people can move on healthily, the idea is that in terms of couple therapy perspective, what we say is a healthy resolution. A resolution that does not affect each partner's mental health, that does not harm a third person. Quite often complications arise if there's a child in the picture, and because of that there are other factors happening. But more and more in the last few decades I've seen that even families are saying when they see conflicts or situations, they encourage them to say, go ahead and take divorce. Nobody's stopping nowadays that much. Most often it is still the individual's own inner factors that stop them, not so much the outer factor, unlike few decades ago. Now, some couple therapists say that actually it's a very psychodynamic view that a couple relationship does not stabilize unless there is a third factor. So the woe factor in some families you may see, in some couples context you may see, the third factor is a parent of the spouse or a sibling who is told everything. So the third factor doesn't always have to be an alternate relationship. When it's an alternate relationship, the issue is very simple. Because a lot of times when it's very clear that the partner, the aggrieved partner, is very clear about what is expected to move ahead in the relationship, and the other person is not willing to create a clear answer or take a clear position. We've seen many couples like that where ultimately it goes in the direction of making a choice that this is not going to work, this is not acceptable. Where it gets complicated is the woe factor, the third factor is a family member, or it's a non-heterosexual relationship. It is a relative, or it's a neighbor or a friend, where the context is different. So what happens in our kind of cultures, people do have a sense of intimacy with people, and not always that level of intimacy with the spouse. It's very common. It's common to have friendships like that. It's common to have a family member or a sibling with whom you're sharing everything. It doesn't have anything to do with attraction or sexuality. So many couples are in difficulties because of that also. Now, those are more complicated. How to help them? The attachment that one person has with one family member, how to keep that part of this life, and at the same time not have a sense of insecurity coming alive in this couple relationship all the time. So those are a lot of variations of what happens in couple relationship, but they do require little long-term work. These are not things that you can approach in the very first or initial sessions. And quite often, even when couples come in talking about it, we often say for the initial few contacts, watch spontaneously what are they talking about, how often they are going on certain themes or the other.
Yeah,
and
thank
then
you.
move ahead.
Sure, may I add to this, Liam?
Sure, sir, go on.
Yes. Dr. Shah, my observation is that I am not speaking of the issue that a couple has come for divorce. Most often we find couples who have come for resolution of their conflict, and this issue of I will mention it as an issue of infidelity. And infidelity can be of two types. It may be delusional and it can be fact. And again, fact can be of two types. It may be admitted by the person who has become infidel, or it may be detected. And issues in all these three conditions differ a lot. And I do not accept that they have come for a divorce, because if it is divorce, why should they come to us? They have come to us because they need some resolution, and they have tried and fought and they have not been able to achieve it. So some guidance in this regard.
Yeah, so I'll add a few points to that. You said it very well that some part of it can also be delusional, and some part of it is more part of an irrational thinking of one person or the other. Now let's leave aside the what goes under the category of a delusion. Okay, usually as a clinician, you would be able to figure it out that this is more the kind of description and all that we are getting, it's more at a certain level. Now, what happens is quite often, it's not infidelity in a technical sense in many other situations. So when we tease it out in the way the couples are presenting, you find it is linked with a less attention here, more attention there. Less attention here or more gestures for so many other people. So it's a certain kind of a level of comparison that the individual is making. So quite often when they present with something like, suspiciousness, let's call it suspiciousness. I use the term in some of my teaching things, I use the term suspiciousness. So one partner is presenting with suspiciousness. When you tease it out, it doesn't always lead back to a specific another person and a third member or another relationship or an alternative competitive relationship. Quite often it narrows down to paying more attention to something else or giving more importance to work or something else at the cost of the intimacy here, affection here, communication here, thoughtfulness here. I reduce it down to thoughtfulness. Leave many other things. Working on intimacy and all again is actually it should be done in a interactional terminology, not at a individual level. Many people believe intimacy formulations they will do only for individual levels. Somebody has more needs or high need of intimacy, whereas intimacy should be looked at the interactional level. But you can bring it down at the level of you can reduce it to understanding what is the communication that's taking place between them, what kind of interactions are going on, what is the quality of those interactions, and in those qualities of the interactions that are happening, what features are there that are creating a sense of insecurity because the partner is having certain other qualities of interaction with another person or with a set of people or with a group of friends or things like that. So when you tease it out that way, it becomes workable. There's something one can do about it, something the couple feels they can do about it. So in the context of that, straight away the command can be that you should not do anything else without me. You should always be doing things with me because otherwise you're doing only things with your friends. If something like that goes on, it goes across as unreasonable demand. The other partner also digs in the feet to say, no, 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 how can I do that? I'm going to have my space. So it becomes completely, goes into an issue that is not the issue for them. The issue is something completely different. The quality of this interaction. What is taken away from that, how that can be built back. Along with that, creating a sense of comfort and security with that, and then you create the autonomy for each partner to be able to do certain things independently. Yes.
Yeah. Thank you, ma'am.
Thank you.
Regular issue, we can say a very common issue. One partner is more inclined to participate in the therapy. Other partner is more of an accusing nature. So there is a imbalance. The two people are differentially involved in therapy, and one is accusing the other. One is more aggressive. So how to approach this thing? And sometimes one partner is accusing the therapist also that you are taking the side of the other person. So how do you handle these issues?
So there are many aspects to this. So one is that there is a context where what one partner who wants therapy and who's in touch with you, what that partner is doing unknowingly is actually portraying a bad picture of the other partner to you. The other partner is aware of that, and that dynamics is actually keeping the other person away. And that's a very common phenomena in couple therapy. So most often this would happen when actually there has been some incident in the history where this partner who's not coming is aware that he would be or he or she would be portrayed as somewhat having done something wrong. And so already it's going to be hard to convince a professional that you could be looked at in a fair fashion. So quite often to different strategies can be used. Sometimes we use the strategy of just inviting a phone call from the other person directly to the therapist, giving communication to each person separately, not through one person who is more familiar with the setting right now, using mechanisms like that. We also have contexts where one partner is not really wanting to bring the other partner, but wants work on the marital issues. And quite often this could be in milder kind of context where for practical reasons or even for it's almost like a kind of a safety of their relationship. Somebody believes or they believe that more than both persons coming in for therapy, one person is visiting, taking some guidance, taking some help, and encourages at home the other person to pick up ideas or concepts or whatever, and through that mechanism change happens. In international research, they used to say that don't do sessions with only one person or with each person separately. That is going to end the marriages and things like that. Years, for decades in between, the research was about that. We find that it's possible to actually do, in certain contexts, it's possible to work on changing the relationship, on changing the system, even when only one person is coming. And we've written something about that also. If you want, you can just write to me. I can forward that article for the group to be making use of. It was from the idea that in a certain kind of a practice setting, you are likely to see a lot of those situations where the other partner is not able to, or not, this partner also doesn't want to bother the other spouse so much to bring that person in work-wise or whatever. It doesn't work. So that's a different kind of a thing. Where both are required a little bit, sometimes it even helps to work with this partner who's coming in to help the person recognize in what way or what kind of a communication is being used to the spouse for coming for therapy, and how to modify that communication. And so how to allow an interaction to happen between the therapist and that partner. To also show, because this position of a therapist, that therapist is going to be somewhat neutral, can be experienced as a little threatening by some partner in the context of whatever histories they've gone through as well. So one has to be a little sensitive on all these matters. Yes, please.
Madam.
Just who should practice this couple therapy? So psychiatrists should do that. In allied fields, who is licensed to do that? How to avoid medico-legal complications while doing therapy? So there was a huge case also in the past, a couple therapy resulting in a lot of retrial. So who is authorized to do that? And what are the medical legal complications that should be and can be avoided?
So very good question. Medical legal complications are very common in couple therapy. So it's very common for couples to go through couple therapy sessions, to reach a position of resolution, and still after years come back seeking records because now they're wanting to go for divorce. So I think most, like in our kind of a context, psychiatrists are very important. Many of these records are maintained under the Department of Psychiatry and they need to be activated or handled from there. Marital enrichment kind of work with milder kind of cases and all what we are doing, that clinical psychologists, psychiatric social workers, many are doing. Now, in this country, there is no basic authorization that only so and so can do and so can't do. Let us just say qualified mental health professionals can do couple therapy. And it's very common. Internationally also, it's very common that not all mental health professionals are trained in couple therapy. Not everybody goes through very systematic formal training in couple therapy, in this form of psychotherapy. But at the same time, still, many can shift to understand and to practice this couple therapy. It's all about being able to, once you know a population, once you know, you can read the population well, and in the kind of setting that you are and the kind of relevance that you can see of this kind of intervention, one can get equipped with that and practice it. Have I answered the question?
Yeah, I think so.
Yeah, madam, over the past 20-25 years of your practice, are the goals of couple therapy changed in the last 20-25 years?
Oh yes, goals have changed. Everything has changed. I've had to learn everything constantly, afresh. Lots of too many changes.
It's like
every time you understand something from the population, then you understand the population's needs, and then you have to go and learn something else to see in what way you can meet the population's needs.
Yeah, ma'am, someone has asked a very interesting question. Any scale or measure of matchmaking so that we don't have to do couple therapy later on? Is there any?
No, I'm sorry to disappoint you, but no. And yes, by the way, on that I'll just correct something in the introduction. The scale that I've developed is marital quality scale, not marital therapy scale. I just wanted to correct that. But yeah, there is no way. Many people have approached me earlier also that, whether I can be part of some group where we can do some kind of work, premarital work, to ensure that no problems happen later on. But I'm sorry, I don't have expertise on that. There is not enough knowledge on that. I don't think research has, or even in I think I can't imagine in the next 10 years also research progressing on that in any way. So some of the things in life will have to be just remaining mysterious to all of us.
Ma'am, someone asked, what do you mean when you say that do not activate personality factors? Suppose one person is having some traits, narcissistic traits or some sociopathic traits. So in that context, in that relation, how to handle this situation? One person you seems to be quite well adjusted. Other one is having traits or bordering on personality issues. So then, how do you handle it?
I think the position I would keep is not to attack that person, but to be able to discover in the conjoined session what aspects of those styles the person is not wanting to change, to bring that out in the open, to make it more explicit, and to elicit this partner's response to that in order to see in what way life can become livable. Any additional work should be based on, a lot of times we have seen couples when they go for, as part of routine procedures, they have to finish psychiatric workups for themselves. And quite often they are told about their personality aspects and all. They don't take to it very kindly. They are not here for that. They don't want an opinion. They don't want a judgment on themselves. Those who want help will take help in their own way. So what we often do is that if something like that is happening, very gently you can put it across in the conjoined session. Gently, if you become blaming and attacking, unlikely you will get any positive response. If your idea is that this person does require some individual attention, individual changes, individual therapy for that, you offer it as an opinion. And you say, I want you to think about it. Don't give me an answer immediately. But this is an opinion for you to consider. And this is not about her or him, what your partner is saying. It's not about just wanting to please the partner. It's about from your own welfare point of view. And as a mental health professional, I would like to give you the opinion that as individuals, if we become very rigid in certain styles, in the long run, they do cause us some difficulties. So it is from that point of view, I would like to suggest to you that there is help available of this type or that type. And over time, over next few weeks' time, you can let me know. But that too, if you know what kind of therapy that person is going through. There are many times when you just have traits, you don't have any tangible evidence about that. So in those situations, all you should do is you should just add cognitive behavioral perspective in your formula of conjoined sessions. And in the same conjoined sessions also keep adding little bit on some of these aspects that you see as problems or deficits in certain personalities without attacking that person. That should be enough. So when you know it's just at the level of traits or something and it's not showing so much of rigidity that you expect. And quite often people just learn how to live with those rigidities also. The other person wants to accommodate to that also. They also basically, when they have a caring kind of attitude towards each other, they don't want to agonize each other too much. They are willing to accommodate to each other's uniqueness as well a little bit. As long as it doesn't become a nightmare to live with. So discover that along with them and address it in that kind of a style in the conjoined session. So sometimes even targeting or offering individual sessions may be experienced as threatening by that person and they may not want it. Give the option always to the partners. If they want individual sessions for any of their work, any of the changes in themselves. Yeah.
Thankfully, we are recording the session, so we'll just keep on playing your statements and learn from it. Amrit, your question.
Okay.
Yeah, not my question. There are a few questions like when do we say no to couple therapy? Like we have a close friend, they come to us for therapy and all. Is it advisable on our part to give therapy? Because somewhere we might be accused of taking sides, somewhere there might be problem. So when do we say no to couple therapy, madam?
See, so it is important if you have dual relationship with any of the partners, it's advisable not to do couple therapy. At the same time, we also know that there is a reality to our setting, and also internationally, also it's acknowledged in smaller towns, in smaller places, in villages, in smaller areas, where just one or two professionals or something. People will actually come to you because they know you. If they know you, then they know you socially also, they'll know a little bit more about you also, but they also want to take help from you. So that's also a very typical aspect of help-seeking behavior across the world. Only in very big cities, people want to go to anonymous people. But by and large, people want to go to somebody about whom they know something or they know a little bit. If you can find a mechanism by which you can balance it out, and the dual relationship is not complicating, it's not too intense, then it's okay to go ahead with it. If your question is only from that point of view, this would be perhaps the position to take. If it is from other contraindicators for couple therapy, it would be a lot of situations where the pathology is very intense, or the moment they sit in conjoined sessions, the processes become so negative and so harmful that you can't believe how they will leave, how when they leave the session, how will they be able to live with each other, So when too much of difficulty is there, even in those contexts, one needs to be careful. If the pathology is very extreme, very long years of difficulties, if there has been very clear indication that the avoidance in the relationship is pretty final, that they are not talking, not interacting, not even affected by each other. They're what I call emotional distance from each other. If there is evidence of emotional distance from each other, no point in doing couple therapy. You can do family therapy. If they are still living together, if there is a family, there are things about the family system to be organized and things are spilling over there. You can do work on that to help them see how some kind of order can still be created despite the fact that otherwise they wish to live like in an emotionally distanced kind of way. Yes, please.
Ma'am, I've seen so many situations. Can you judge, or what are the indicators that you understand that the therapy, that they are going to drop out, the couple is going to drop out? So how do we judge, how do you gauge that the couple is now going to drop out, the therapy is going towards failure, or this?
Dropout, in my view, I think it's advisable not to judge it, because then we might become biased towards them if we start deciding beforehand itself. And it's often a surprise. To me also, even now, it's always a surprise when somebody is a dropout. And I'm always wondering, and I'm always waiting to see when would they get in touch next time, when they get in touch next time, what will I come to know? I worry a little bit about them. And I think it's useful not to preempt that. And not all dropouts will be because of negative things. Some dropouts hopefully happen when they benefit from the session. But please remember, couples are actually very good in their judgments. They're the most empowered psychotherapy population that you will come across. They're very empowered in many ways. They know very well what works for them. They know very well when a session goes bad. We've done a lot of research on their reports, lot of research evidence. If you visit NIMANS sometime, you can read all those dissertations and theses. They have so much of knowledge about the way they experience the sessions. They know so well what they expect in a session. They want neutrality. They don't want to go to a person. Because of the fights, they end up pulling people on one side or the other. But intelligently, they know very well they want a person to whom the spouse is also willing to sit and listen. They don't want a person to make the spouse go away from the room. So they are very, very aware of what they can expect from a session and what they can get. So we often have dropouts when we know that they see either some kind of incompetence, or they see too much of change of therapists in our setting that happens because of the training context, or even that context. They don't want to go on talking to new people all the time, which hopefully if one is in an established setup and you alone are seeing the family, you would be able to make sure that those kind of things don't happen, so your relationship is not, it's a primary relationship, it doesn't get disrupted. So quite often when they don't find that, that can become a reason for dropout. They find, if for example as a therapist, if you see a session actually went bad in a certain way and you didn't recognize it during the session, but after the session, you remembered one or two moments when something was said, something you said, and some reaction from the other person, and then something went along in a wrong way. And so you can anticipate that some difficulty might be connected with that. So if there is anything, what we call therapeutic ruptures happen very often, and they're very common. Therapeutic ruptures actually, it's again a concept that has come from Therapeutic Alliance research, and it's very common, and it's actually many therapists say that they are essential for good therapy to progress. But when therapeutic ruptures happen, as a therapist, how you recover from that, how you help them recover from that, and then how you reconnect in the therapy process, those things can become very powerful. They are quite meaningful. But at the same time, even respecting their decision, it's quite all right to be able to hear that. We often don't want to hear from them what they have decided. We feel that we will decide the next session. We will decide when they will come. We will decide how many times. Not in couple therapy. They will often decide. They will decide how often they want to come. In our other contexts, we give them the flexibility of coming, seeking appointment, taking a decision whether they want to come as couple or as individual, letting that decision be flexible, that as a therapist, I'm offering whichever way you come. When you take an appointment, do come. Whichever way you can come. If you've had a fight on that day, you may end up not wanting to come along. Let your partner come. I'll make some sense out of whatever visit you make, and we'll see in what way we can still progress. So having that kind of a flexibility in offering something that is relevant in the context of the relationship, even if at times it's one person coming, at times another person coming, at times both are coming, even in that kind of a thing, it should be all right.
Well, when to recommend separation? Now
Sorry?
things can't be worked. When to recommend separation? Like things now
Oh no, you don't
have.
have to worry about that. They will tell you. It will be there in your face. And separation is nothing very, very rare nowadays. You'll find, like, I don't know how it is in other cities now, but over here, I find practically every couple has had some period of separation or the other. And in in one small research we did, we actually wanted to understand this a little bit more. We found that they are looking at separation as a testing out phase, that how separation will actually in some ways solve their problems. So they actually look upon it in a very different way than the way we do. So histories of separation are very common. Now separation because of practical reasons are also very common. And those bring about different kind of marital conflicts. Many couples have long distance relationships for years for various reasons, or they go into a long distance relationship at a certain phase because of work or job or studies or this or that. And then after years, when they are in their late 30s or 40s, then they want to start living together, and then there are new kind of challenges. They are an older couple, at the same time, they are not, they are almost like in the first stage of marriage kind of a thing. So it comes with a lot of other kind of complications, the separation element. And basically, it's something that if a therapy process is good, they often reach a very clear decision about it in their own way. So it's not uncommon for a good therapy process to go in a certain way where at one point of time somebody informs you, one of the partners informs you that we have reached this decision, that it's now, we are all right with it and we are going to end this, but we only have to tackle these other practical difficulties. So, but even then you can offer sessions in case they want discussions about how the process should not affect anybody's mental health. And especially more complications if they are children and other systemic complications in the family and things like that. Yes, please.
Amrit, your turn.
My term, it's, madam, I think it's almost, we have exceeded our time limit. Thank you for a wonderful session. I just wanted to ask last question. We see a lot of couples who live a married life but who stay in two different rooms in the same house, madam. No interaction emotionally, no interaction physically. There is nothing there, but they just stay together in two separate rooms. No fighting, no conflict, nothing. So these are some of the cases we see. Maybe we'll take up a lot of things later on, madam. I
Sure.
think we'll take a pause. Many
Yes.
of us, many of them have requested you to come again on this platform, maybe to enrich us on another topic we'll be discussing with you on the private thing. Chat. Thank you so much. Dr.
Thank you.
Majid, your last final comments, and then I'll hand over to Dr. Subhendu.
It has been a marathon innings, long double century by Madam Anisha, and it has been lovely to listen to her and deliberating upon various issues which are in our day-to-day practice that we experience as mental health professionals. Dr. Amrit, I fully endorse and agree with you what you said, that we would like to have Madam again, and will be very honored to host you again, ma'am, under the patronage of Dr. Tufan sir, and Dr. Aleem is there. And there are people who are waiting for asking a lot of questions and interacting with you and which city you are actually living in. Madam is probably still in Bangalore. There are a lot of people asking about you. So you are still in Bangalore to my knowledge, and it has been an exciting session all the way since we started at 8 p.m. and it's almost nearing 10 p.m. now. Thank you very much, and thank you everybody, all the participants across board. We had very senior psychiatrists participating in this event, starting from our office bearers up, even IPS, most of the people were there, IAPP people were there. I have to name, and it will take me probably till 11 o'clock in the night to name all. So thank you all, moderators, Tufan sir, and the IPS Odisha State Branch especially, for organizing this lovely event in the evening. And thank you very much. Thank you all.
Thank you.
Thank you, Dr. Abdul.
Thank you, madam.
One more
Thank
minute. Sir,
thank
you
you,
wanted
madam.
to say something?
Yes, sir, just I want to tell thank you, and I have received minimum 50 WhatsApp messages individually that we should repeat this session. So hats up.
So
Before you end, I would like to share that I wanted to go through the book you recommended by Guruman. I could not go through it, but what I perceive, the cultural context of that book is totally Americanized. All the authors are from US, and we have to develop a guideline, maybe pioneered by you, that is appropriate for Indian socio-cultural context, because that is also important in couple therapy. I hope we will have it, and we'll discuss in the next program. Over to Amrit.
Okay. Thank you.
We had more than, madam, 1 minute. Just our state branch, our secretary, Dr. Subhendu Nayan Mishra, Honorable Secretary, is online. He wants to, it's a formal event where we have to thank everybody. Dr. Subhendu, are you online? Pawan, Subhendu? Can you unmute Subhendu? Dr. Subhendu? Pawan?
Yes, sir. I'm unmuting him.
Yeah, please. So we had a record number of registrations today, more than 770. So
781.
Mind-boggling. Subhendu?
Sir, he's not there, I think.
Yeah, I'm here.
Yeah, he's there.
Yeah.
Please,
Should I start?
Yeah, please.
Yeah. On behalf of Indian Psychiatric Society Odisha State Branch, we are very much thankful to our speaker, Dr. Anisha Saha, ma'am, for excellent talk on the couple therapy. We are thankful to our chairperson, Dr. Rajesh Dume. In spite of his wife's ill health issue, he was there with us for some time. Thankful to Dr. Abdul Majid for chairing this session. He, as you know, he is always active in this type of activities and on the Thursday musing. Last time also he was very active. Thankful to the organizing secretary, Dr. Tofanpati, for arranging such nice activities every Thursday on these musings, Thursday musings. Our dynamic organizing secretary, both Dr. Amrit Parjoshi and Dr. Alim Siddiqui boss, for excellent organizing this Thursday musing. Last but not the least, the audience, almost 800 something. Thank you all, everyone, and good night.
Thank you.
Thank you, Torrent, for giving us the platform, doing all the backroom, and we have a good technical team work helping us in choosing the speaker, topic, and all. Thank you, madam, again. It was wonderful listening to you. We hope we'll listen
Thank
to
you,
you again.
everybody.
Thank you,
so
ma'am.
much.
Thank you,
everybody.
boss.
Okay.
Alim boss, bye-bye.
Thank you, everybody. It is our pleasure to be host of this event.
Thank you very much. Thank you, everyone. Good
Thank
night.
you,
Good night.
Majid boss.
Thank
Thank
Abdul
you.
Bhai.
Abdul Bhai
Good
is a
night.
hero
Good
always.
night. Good night.
Nice.
Good night.
Fantastic.
Bye-bye. Good night, everyone.
तो
Bye-bye.
वो कहाँ गया? अर्चना को बाय कर दो। चलो, thank you everybody.